morning, everyone. Thank you very much for your interest in women's health, and I just want to acknowledge the fact that you're here on a Saturday morning, which really does show your commitment. This morning I printed out some notes, and now I know it's because it's to support my hormonally induced cognitive decline. So we'll see how we go. Why is this important? We've all been to the same medical schools. We all know about dysmenorrhea, primary, secondary dysmenorrhea, how to treat it, all the usual stuff. But it's still really difficult to treat. And what we do and what we're taught doesn't work for everybody. And the reason for that is because it's really complex. So today, what I want you to come away with is to think in terms of multifactorial pelvic pain, know how to pick up serious pathology, and more importantly, have some ways of really reaching your patients. Because I think we've all had that situation where you're sitting in an appointment and you know you're just not really quite hitting the right note and they're not really buying what you're selling. I was a bit overwhelmed when I was given this topic because it is so complex, and I thought, wow, 15 minutes, there's no way you can cover dysmenorrhea. But then I realized that that's what you guys face every day in your appointments, and you have to do it in 15 minutes. So I thought we can probably get some of that done, and we'll see how we go. To make it more easy to do that, I'm just limiting this to women who aren't seeking pregnancy. So we are talking about the group of women who come in with dysmenorrhea, where you can do your usual initial treatments, rather than talk about fertility and all of that, which just would open another can of worms. So when I finished my gynae training and I was employed at WDHB, my job was to look after endometriosis patients because of my advanced lab training. And I found myself with a lot of questions, and I took myself off and did quite a lot of research, went to quite a lot of conferences. And I'm going to start off by just giving you the key concepts that I've found incredibly helpful and that really have a big impact on every consult that I do for these women. This article told me what it was that I was doing wrong, because I thought it was all about explaining the pathology, giving the medications, and that was what my patient was after, but that was what I thought they were after. This study looked at 7 different studies, so it's a review article, and these studies were all about investigating what women want from their appointments with us. And for all of these studies, one of the main things was that they want an explanation for why they feel pain. And I think if you skip this point, you will come away from your appointments feeling like you've missed something. Other key things are legitimization of their pain. They want personalized care. Guidelines are really important. They help us know that what we're doing is reasonably safe and medically justified. But you need to tailor it to your patient's particular situation and consider whether what you're telling them to do is going to fit in with their lifestyle. And they're also wanting reassurance. If you don't understand what it is they're wanting, then your outcomes will be poorer, because when you have mismatched expectations, things just aren't going to go quite so well. The main explanation that my patients really seem to get really excited about and their light bulbs start popping off is the concept of why a period actually hurts. And we all know this naturally, but how do we explain this to our patients? I have a model in my appointment, and I'll show them the endometrium, I'll tell them how the hormones impact it, and I always point out that when you bleed, shedding the endometrium causes inflammation, and inflammation hurts. So the muscle of your uterus hurts, and then to get the blood out, the muscle contracts, so you've got an inflamed muscle contracting, and you have to squeeze this blood out through a little hole in the cervix that's not very well designed, so it's like contraction pains. If your periods are particularly heavy, or even with a normal flow, if the hole in your cervix happens to be small, then the blood might go out through the bigger holes at the top. Inflammatory blood sits in your pelvis, and all the nerve endings will tell you that you're bleeding to death, which is quite excruciating pain. So those are all the physiological reasons why periods hurt. And that little inset box is just to remind you that as we go through puberty and become an adult, the uterus is very different, and primary dysmenorrhea in teenagers, I think, is largely due to the small shape of the uterus and the fact that it's just not quite ready for this job. And that's why there will be a proportion of adolescents that, if you can nurse them through this initial phase, will come right with a bit of time. The next key concept, which really did blow my mind when I started applying it to my appointments, is this cascade of events. So with any kind of pain, particularly if it is repeated, it starts off as a peripheral stimulus, often because of the physiological reasons we've just talked about, but then you can bring in your adenomyosis and the endometriosis as well. In response to pain in your body, regardless of where it's from, so for example, if you break your arm or you put your neck out, what will happen is the muscles in that area will contract to protect it, and that makes sense, right? You want to heal, and then as it heals and you go back to normal function, all those muscles will relax. If we're talking pain in the pelvis, the muscles that will contract are the pelvic floor muscles, and over time, they're very clever. They become very twitchy, and little triggers of pain will make them contract, and you can end up in spasm, which causes excruciating pain. The way patients describe this often is like a sharp stabbing pain, and I'm sure you'll be familiar with this language, like someone's knifing them in the ovary. It can go into the hips, into the back, down the legs. If you think of the function of the pelvic floor, it all kind of makes sense. It can be worse at the end of the day, worse with coughing and sneezing, moving, sex, full bladder because the pelvic floor's really contracted to stop you leaking, full rectum with constipation. So that can be a reason why pain can generalize outside of periods into between the periods as well. And this is one of the most common reasons why patients will present to hospital. Over time, with lots of pain triggers and pain load, human beings become centrally sensitized. And this is a separate thing to the dysmenorrhea, and some people are more prone to it than others. Over time, not surprisingly, there will be psychosocial effects. Next key concept is the pelvic floor spasm and anxiety cycle. This is really important to explain to your patients once they understand the relationship between their muscles and the pain. Pain for your body is a sign of danger, and it will raise your stress hormone levels. So you will feel anxious, and that is what you're supposed to feel. It's appropriate to the pain, but if you're going to have this pain ongoing, it will become physiologically exhausting. You'll end up with headaches, depression, anxiety, and it is important to really get into that cycle, stop the pain, and manage the anxiety, because you can modify that emotion. That anxiety puts you into a fight or flight mode, which will make your muscles tighter, so you're ready to go. And this is the point at which you might end up in hospital, getting lots of investigations which are normal, and coming away with the messaging that you might be a little bit crazy, which is not helpful. When I'm assessing somebody with painful periods, I am trying to determine with my history where exactly the pain is coming from. So is it uterine, where it's kind of crampy, contraction-like central, and it's associated quite often with passing clots? Peritoneal, as you know, a more constant kind of pain, might be associated with a bit of rebound. Cervical motion tenderness can often happen around ovulation because you've got a bit of bleeding and peritoneal irritation. Can also happen with retrograde menstruation. Muscular pain, the things that I talked about before when we were talking about it. Bowel pain, you know, all the symptoms of IBS, which is very common in this group of patients. So the looseness, constipation, bloating. It's not enough to say, how are your bowel motions? Are they okay? Because if that's their normal, that's what they'll say, they're fine. You need to dig in and really ask about those symptoms. The reason this is important is because these symptoms will change with your cycle because of the hormones and also because of the stress hormones changing. And you will often find that those symptoms exacerbate during the period, and you need to treat them separately from the actual dysmenorrhea. There's a nervous component of the pain, particularly for people who are centrally sensitized. And then, of course, there's the psychosocial aspects of all of this as well. And through the patient journey, it is a little bit like whack-a-mole, because these things will become important at different times of the cycle and their lifetime and their fertility lifespan as well. So your job is kind of to determine at different points of time which one of these is the big problem, what's causing a flare-up, and helping your patient to manage it. So when you find yourself in a 15-minute consult, how do you tackle all of those things and get through them? You all know how to take a history, and you know your health pathways and all of that stuff. The way that I frame these patients when I'm seeing them in clinic is, firstly, is this a mostly gynecological pain where the symptoms are clustered around their periods? In which case I'm really focusing on uterine cramping, retrograde menstruation, adeno, and endo. And then it's pretty simple. Stop those periods if you can, or make them lighter, or decrease the inflammation. So you start your initial therapy, you give them the explanation of how those things work, because the explanation will help them with their compliance, and understanding what's going on and the process that they're going through will decrease pain levels as well. And then give them resources. And I've got a slide in a moment that will show you the resources that I find particularly helpful. And then, of course, you make your follow-up to check their blood pressure if you've started hormonal therapy, and to assess the response, and to organise ultrasound if they haven't gotten better. The other big chunk of patients that I kind of conceptually bring together is the group of patients where, yep, they've got their terrible periods, that's a real problem, but in between they've got these random complex pain symptoms as well. And this is where you're a little bit further down the cascade, and you've got the muscle spasm, a bit of high-tone pelvic floor. You might have dysmenorrhea as well from that. You've got a whole lot of gut symptoms. Your bladder might be causing some symptoms, and there's quite often a lot of psychosocial stuff going on as well. So it's good to very rapidly pick out these patients, know that you've got a lot more work to do with them. Yep, sure, you start your initial therapy because it's really helpful to just take something off their plate. And if you can stop their periods and reduce that inflammation and take that off the table, it just simplifies things, and it gives you a chance to start working on all the other stuff as well. So you start the initial therapy, you give them their explanation, and the resources that this group really need is the information about all the other kinds of pain, because invariably patients have seen a lot of stuff about endometriosis in the media, and their focus is on this, which might be part of the problem, but is very rarely the whole thing. So what you want them to do is have their homework, go away, read about muscle pain, gut pain, nerve stuff, central sensitization, bladder, and some of the psychosocial impacts, so that they can tease out what's going on in their body, and when they come back to you, they can tell you what's going on, and you can direct them to get their treatment for that. So the second appointment for this group of people is really digging into what's going on, identify all the secondary diagnoses, and making a plan for that. Whilst you're taking your history, the things that you need to pick out that will give you the group of patients where endometriosis is more likely a factor, and you need to keep a close eye on them and make sure they get the right treatment for it, will be people, and a lot of these patients will have multiple ones of these, cyclical, chronic, or acyclical pelvic pain, especially combined with nausea. The nausea is often because of the inflammatory cytokines associated with bleeding. Dysmenorrhea, dyschezia, dysuria, dyspareunia. Risk factors: positive family history, obstructive genital malformations, early menarche, and short cycle. When you do your bimanual, you can just do single-digit examination. You're looking for mobility, tethering, cysts, and nodules, and also examining the pelvic floor muscles. So the way you do this for obturator interners is you get them to push their knee against your hand, so externally push against it, feel down there. Often it'll be tender and replicate a lot of their pain, or one kind of their pain, and levator ani as it shows in that direction. Your safety points are to exclude pregnancy. On examination, you need to feel ovarian cysts and document whether there is or isn't anything there, tethering and reduce mobility. For your ultrasound scan, which I would recommend ordering if your initial treatment fails or if you've got abnormal findings on exam, dysmenorrhea significantly impacting quality of life. This is what you write on your form. Despite hormonal treatment, please identify any signs suggestive of severe endo. Query ovarian cysts, query ovarian mobility, query rectal sliding sign. Please exclude Müllerian tract abnormalities, and then just document risk factors, because, as you know, it's not easy to get one of these scans in the public sector. Sorry? I've only got 4 minutes left. Setting expectations about the initial treatment. You really need buy-in for this. So the hormones and analgesia are only going to work if they're taken well. You need to explain how to take the analgesia. Often, if they can predict their periods or when the pain's going to get bad, start it the night before, take it regularly, keep the therapeutic levels high and steady. Give the pelvic floor stretches. You can find them on the first website that I'm going to show you in a moment. Explain that you need to really work on these muscles and undo a whole lot of involuntary learning, and it can take weeks to notice improvement. And for those muscles to really relax, you need to be quite aggressive with all the different pain triggers so they don't keep tightening up. Make it clear that hormones aren't like Panadol that work immediately. It's going to take a few months for them to have an impact on the body and really show you if they're going to work. And explain that if the pain continues, then you will refer, because a huge number of patients who drop out of care do that because they receive the message that things are fine, it's normal, here's your treatment, and see you later. And because they will be worried about endometriosis, explain that the ultrasound will rule out the very severe endo, and if there are signs of that, then it will warrant referral. So you do all of that stuff, and then you get the feeling that they really don't want to take the hormones. At which point, you need to explore the concerns about endo, because these patients will have seen it in the media. Explain that the pills decidualize and atrophy endometrial tissue, and if your periods are well managed and the pain goes away, then that is an indicator of endometriosis suppression, and you might be able to avoid surgery until it's going to be more useful. If you have a normal ultrasound scan, then diagnosing endo usually requires laparoscopy. And if the hormones work, then it is better to defer surgery till you're a bit closer to fertility, because surgery for minimal endo does enhance your baseline fertility. And people really respond to this, because very few people really want to have surgery. And you can discuss coming off the hormones closer to childbearing and seeking investigation then if they're really quite anxious. These are the resources that I'd recommend. Ooh, the colors have changed. Sorry, they're not very readable. I thought I'd made them black. Sorry, but they will be on the website. First appointment messaging. So there is the info that we give and the medical facts that we explain, but the messaging is important. Women are very intuitive, and what you want them to read between the lines is that you believe that their pain is a real problem. And if the period pain stops you doing things, then it actually needs work, and they need to advocate for themselves and come back. If hormonal treatment and simple pain relief don't work, then a laparoscopy to look for and treat endo may be helpful. And we're there, I may be out of time. But this is the slide when at the end I was looking for images that show persistence and courage and confidence and all of that kind of stuff. And then I thought, oh no, I'll just have a look and see what it says with overcoming. And looking at all the pictures, this is the thing that really I looked at and thought, oh, this is like my appointments, where you'll come across an obstacle with the things that you do, where there'll be side effects or it doesn't work or whatever, and you just have to find a way forward through it. So yeah, that's the image I thought I'd leave you with.